So true to their words, actually, as Dr. Lal and Dr. Hastak, we've heard both, and Dr. Hastak actually says about how we can actually be better equipped when there's problem at hand, and Dr. Lal again saying how we can be better equipped and ensuring that we anticipate the problem well in advance. So I think it's a great presentations, I think, and very important. I would want to actually, take a deep dive into some of the points touched upon in the presentation. If we could actually begin with Dr. Lal, you mentioned about this blood biomarkers. I mean, as a pathologist, you're now entering the realms of radiology as well, and in terms of actually kind of merging the two, as it were, in some sense. So how we can actually, this concept that you have about this biomarkers for ischemic stroke, which is of course one variety of stroke. The other, of course, I think in the hemorrhage case, I think there's pretty little that can be done at the moment. So, how can we actually broad base what you're saying, and how we can actually, what's your thought process? Because this unfolding of this blood biomarkers, as it were, if you can say a bit more in terms of how we can actually ensure that it goes into larger circulation and more into the government setting as well, because here the whole approach, at least of this session, is to have an integrated approach towards dealing with this problem. So some thoughts there will help.
Yeah. So thank you, Mr. Sharma. Actually the starting of the whole thing starts with the patient himself, who has to realize that something can happen to him, and it is not always the other person who suffers, it can be himself. So this is the first realization which I would request everybody to consider, that you always think that, well, my house is not going to be burgled, it's always the next house. So similarly here, the problem with the non-communicable diseases which I mentioned in a short while back, or these are also known as lifestyle diseases, this has to study, or this has to start right in childhood. If you ask me, when the child is growing up and all of you are coming from affluent places, etc., you have to start telling your children that, well, you will not overeat. The obesity in children now has reached all kinds of parameters now. So you start catch them young, and catch them young means that you tell them to eat good, they should exercise good, they should stay away from junk food, they must do an exercise to keep themselves fit. And when these people come into their adulthood, etc., you would be shocked to hear that when we are still hearing 26-year-old guy dying suddenly of a cardiac episode, and a 29-year-old, etc. So the fact of the matter is that India, because we have such large numbers, you are going to have these problems at your doorstep. In fact, they've already opened the door and come inside. So the very first thing which I would like to emphasize is that you have to keep diabetes away. Diabetes is a combination where your parents also come in. If your parents have been diabetic, or one of them have been diabetic, there are more chances that you can become a diabetic. So you have got to realize that, well, diabetes is something which is also self-invited. So one part is the genetics part, the other part is your the laziness part, or the problems in your kind of lifestyle disease. So diabetes is one. It must be, I showed you a test by the name of hemoglobin A1C. This detects or tells you how your average blood sugar for the last 3 months has been. So blood sugar fasting is good enough. If it has to be much below 100. And hemoglobin A1C should be carried out at least once in a year for people who are non-diabetics, or who think that they are non-diabetics. And with that, we have a combination of lipid profile, which there are tests in the lipid profile, starting with cholesterol, triglycerides, HDL, LDL, and VLDL cholesterols. This requires a 12 hours overnight fasting. I suggest that anybody over the age of 30 or 35 should have all these tests: blood sugar fasting, PP, hemoglobin A1C, the lipid profile, the kidney and the liver function test, at least done once in a year. And if there is some problem, you can come back to the pathologist every 3 months, and we will, monitor it for you. And the trick lies in keeping people away from emergency services, which Dr. Shirish was telling, is to keep fighting with the pathologist. So when you come to me, I will tell you straight off, well, these parameters need very tight control. So it's not only control now, it's a very tight control, because you don't know. We cannot tell you when your kidney will get affected by diabetes or by high blood pressure. And when most of the stroke patients have a combination of all these problems. They may have diabetes, they may have high blood pressure, and sometimes, of course, they can have even normal parameters. But that's not the issue. The issue is that you must know about it. So that is the first thing which I would like to emphasize, that the 65% of our population in India is now below the age of 35, and you are sitting on a time bomb. 65% of the deaths which are happening today are happening because of these lifestyle diseases. So again, let me emphasize, diabetes, high blood pressure, cardiac problems, cancer, liver, kidney, lungs, stroke, smoking and obesity, in that order. So these are all the things which you can actually push back a little bit by being slightly careful. I would like to emphasize here that in 1950s, there was a study in America which was started, known as the Framingham Heart Study. It discovered something unique. Till then, nobody knew that cholesterol was actually, associated with heart disease. Of course, now you may have heard something else, that cholesterol is good for the body, etc., etc. So don't fall into that trap. A high cholesterol has to be controlled. There are no two ways about it. A high cholesterol will form all these plaques, which means occlusion of your carotid arteries and your heart arteries, coronary arteries, etc. So you have got to be careful. The patient must become more responsible for his own health. And you must get these things, done at least once in a year. If things are normal, you come back next year. If things are abnormal, please come back to us within 3 months.
Yeah, thanks, Dr. Lal. I would want you to hold your thought, because I think part of the agenda here is actually to look from a national integrated policy also, some of the components that you mentioned, how they can be fitted into that. But before that, to Dr. Hastak, you mentioned a very important point about this ENLS, which I think is very important and addresses the crucial issue of the system and correcting the system in place. One problem which, to what extent, the whole issue around stroke is a patient reaches the doctor and he is not scanned in time, and all the problems that follow up after that. PTA can be administered that of course is one thing which can be done, but we are not a litigant society. So is there some element that what you mentioned, there can be an element of accountability in this? Suppose if a patient has come in and he's not been scanned and he is after scan not been administered TPA, he is held accountable. So those components, because the point is about again the
policy.
Yeah.
I think the whole problem really is about getting the emergency physician to not think that stroke and other neurological emergencies, but stroke specifically, because 50% of emergencies neurological are strokes and 50 are non-strokes, but to understand that this is not a neurological problem. This is a problem which is a dire emergency. It kills you. And understanding the connectivity of the system is very, very important, because what has happened is that, we've had these debates a number of times in the Indian Stroke Association and so on, that, who would thrombolize, who should not thrombolize. And as you saw that the orthopedic guy also thrombolized. He probably thrombolized better than the neurologist. The reason I think it happens is that, you need the emergency physicians, at present the emergency physicians are a completely neglected lot. I mean, you have to understand what happens in the emergency.
Yeah.
In the emergency, the guys who don't get any other specialty go into emergency. And they are not really trained for emergencies. I mean, the hospitals I'm talking about private hospitals. I mean, in public hospitals, it's a little different because there are, but even public hospitals need the systems to be in place. You know, because there are all these loose ends. The loose ends of the private hospitals are basically these not well-trained doctors in the emergency.
Yeah.
And the loose ends of the public hospitals are that, you know, it's, unless you have a passionate professor like Padma, you know, or like Khurana and so on, you know, the system doesn't work.
Yeah. The
So I think that's the two
The other
loose
quick
ends.
point before I look in terms of summing up the points is that, see, since you come from a leading hospital which has looked at that, you yourself have seen, other than the points that you've raised, to bring in a new component which is essentially about how does one actually look at while we've dealt with prevention and treatment, the last important component is that of rehabilitation. Sure. And also involving the families, because what happens is actually we have cases where the whole family has to deal with somebody who's probably for the next 10 years going to be bedridden. Sure. So how about awareness creation from outreach programs that, you know, hospitals can do? Some bit that you can say before the final, after that the final round, in terms of the points that you've said, how that can be brought into an integrated policy that we talked of here. Sure. Same with Dr. Lal, and we'll conclude with that.
Sure. I think the rehab part of it is you see, what really happens, what really upsets me more than the rehab is that we allow that guy, that person whom you have an opportunity to get brain damaged. And then we talk about rehab. See, what I'm trying to say is not that you should not do rehab. I mean, you should do rehab. Rehab is great. I mean, you need 3 months or 6 months of rehab, and we all know that the returns on rehab are very small. I mean, that's why all these other, systems exist in this country, because rehab really is again a very, very difficult area. I mean, I've been at Kokilaben Ambani Hospital, which had a great rehab center, and they have invested, I don't know, crores and crores of rupees into rehab. But at the same time, their returns on that are small, and they can afford to do those type of small returns, big area. But even in the areas where you have actually big returns, you are not working. And I think that's where the government hospitals, if the government puts in a certain, sort of minimum requirement, which they have not put in. You have to only put in a minimum requirement. I mean, you just pass a law that, you don't allow emergency physician unless he is ENLS trained.
Yeah.
No, something of that sort. It doesn't happen.
What I was mentioning, doctor, was that, see, when we talk of data protection today, that is being debated today, most hospitals say that what is being now talked about is a best practice being made a law. So now it is to be enforced.
As opposed to this is the lowest level of standards.
Yeah.
No, what I'm trying to say is ENLS is not the highest level of standards. It's the lowest level of standards in the world. And out of your 5,000 hospitals, you have only 10 hospitals on the website. And of them, I think there are 6-7 who have just done some courses. And the other hospitals don't even exist.
So who takes the onus now to broad base it?
I think it has to be the government. I mean, the government is in the best place to take an onus on it. I mean, they have the power to take the onus. The private system doesn't have a power. Okay. I mean, we don't have a hierarchy. There's no hierarchy. Okay. It's zero hierarchy system.
Okay. Dr. Lal, your thoughts in terms of summing it up from a perspective of how to have an integrated policy in this?
So the government of India, which is protecting our constitution, it's written in our constitution that health or good health is your birthright. And the government of India, unfortunately, has not been carrying out its task so far, and that's the reason why you still find that 4% of our GDP is spent on health, out of which the government spends only 1.1 or 1.2%. So you can't give, what you are mentioning, across the board here, when the spend is so less. So the reason why the private hospitals have come up is because the government, took a backseat all these 30, 40 years. The first All India Institute was, started off in 1956 or 57, and now you are hearing that more All India Institutes are coming up, one in each state, and they don't have people to teach them inside. I mean, there are no professors. So there
I think it's a very good point, because I think if you've seen the states, which was the presentation earlier, the states like Himachal and others, which have actually greatest spend on healthcare, have actually tended to do better.
So this is no kind of a rocket science now, and America is spending 17-18% of GDP on their healthcare, and there still are many more dissatisfied Americans, and UK is spending about 7 or 8%. So in India, if you're spending 4%, out of which the government spends only 1.1 or 1.2%, well, you can forget about good healthcare. And let me be utterly straightforward and frank about it. This kind of a treatment which you're talking about, this is unheard of. In the government of India's, the National Program for the Control of Diabetes, etc., NPC-DCS, the only test which they would like you to do is a blood sugar test, which is not good enough. So I've already mentioned, I'm not going to repeat myself again, but the whole thing has to come up. On the one hand, you have, world-class doctors and world-class facilities, etc., etc. And by the way, the point which Dr. Shirish missed out was that Dhirubhai Ambani himself, after creating the hospital, suffered from a stroke himself. So I would have hoped that the Ambani family would put all their, force and money, etc., into, treatment or prevention of strokes. But you would be, not very happy to know that they are actually coming into pathology now.
No, to be fair to them, I mean, they did set up one of the best rehab centers in the country. And, I've been a part of that rehab center at the Kokilaben Ambani Hospital. So, yes, but I think the really what we lack and where we really miss out the bus completely, I think is the system. I don't think we miss out the bus in infrastructure, money. I mean, we put there as, our sort of this thing. But where we really miss the bus very much, and where we can catch the bus. It's not a difficult bus. ENS is not a difficult bus for the government to do. But where we can catch the bus, it's a low resource bus. But it needs to be sort of put in place.
Okay.
Like ACLS has been put in place, ENLS can be put in place.
Both have actually individually summed up their whole point of view. But just as a journalist, I can't avoid it. One point, in this country, we don't have right to health, but we have right to mental health. As far as here, practitioners of stroke, they understand neurology more than at least a journalist. What would your thought be on that? What should we do as far as strokes are concerned? One specific thing which an integrated policy must have, just one line, both of you.
Control of diabetes, high blood pressure, cholesterol, etc., in one line.
I think just remove the salt from the table. That's it, one liner. Thank you.
Okay, thanks. Thank you so very much, and really nice hearing both of you and learning a lot. Thanks.
Memento for Dr. Arvind Lal, the Chairman and MD of Dr. Pant Labs. A memento for Dr. Shirish Hastak, Regional Director Neurology and Stroke and Neurocritical Care. And a memento for Mr. E. Kumar Sharma, Senior Editor, Business Today. I would request all of you to please gather for a group photograph.